Good morning, everyone. Thank you very much, sir, for that kind words. It's always happy to be back in Kandy. And I take this opportunity to thank Kanchana sir and Manjula sir, who were and are always my teachers and trainers. And all, I thank KSM and Slaus for giving the opportunity to talk on this topic, urinary tract infection in females. We're going to cover the basic terminology or definitions. Etiology of urinary tract infection is general. The battle between host defense and virulence of pathogens. How are you going to approach assess a patient, and then an outline of management of cystitis and pyelonephritis. Special population like pregnant women and post-menopausal women, and then talk on recurrent urinary tract infection. So even in Western countries, the prevalence is high and the incidence is rising. In UK, if we take almost 1/3 of the patient will have at least one episode of urinary tract infection, and 30% of them will have recurrent urinary tract infection. And 1 in 3 women will have at least one episode when they're getting like 24 years old. On the other side, urinary tract infection accounts for more than 7 million admission in US. 7 million GP consultation and more than 1 million admission in for urinary tract infection treatment. And NHS has spent £434 per patient in 2013, which will be more higher this time. Classification depends on the anatomical level of infection. The severity, it can go as simple cystitis to urosepsis, and microbiological finding whether it is bacterial, viral, or fungal, or even protozoal. We'll go through simple definition. Urinary tract infection is an inflammatory response of urothelium and usually associated with bacteriuria and pyuria. Isolated UTI is an occurrence of UTI at least 6 months after the previous urinary tract infection. And recurrent UTI, it should be more than 2 for the last 6 months or more than 3 for the last 1 year after a well-documented, treated, and complete resolution of an UTI. It can be persistent due to same organism where the focus is still there in the urinary tract, maybe due to reinfection by different organism, which is more common in recurrent UTI. This is due to susceptibility of the patient. Complicated UTI, Dr. Anga Vikramadja is going to talk about this on this topic. This is due to anatomically or functionally deranged urinary tract or in the presence of a disease which will increase the susceptibility for infection. We know that pathogens they have the ability to cause disease, and the ability or degree of pathogenicity is called virulence. And opportunistic infections are due to infection due to commensal organism or non-pathogenic bacteria. Unresolved infection is failure of treatment or resolution of UTI and cultures or persistence of bacteriuria despite of antibiotic. Etiology, majority due to bacteria and commonly due to E. coli, accounts for more than 85% of community acquired and more than 50% of hospital acquired urinary tract infection. And rarely due to virus and fungal, even protozoal infection also there. Etiopathogenesis is mostly due to ascending infection. There may be cases like hematogenous or lymphatic spread as well. So we are going to talk about the defense or the battle between host defense and the pathogens virulence. So in physiological voiding with physiological interval and voiding pressures, it's important to avoid urinary tract infection. Commensal periurethral flora and the presence of Lactobacillus acidophilus, which will cause formation of lactic acid, which will reduce the periurethral or vaginal pH. and it will reduce their colonization with E. coli. Presence of uroplakin in the urothelial cells or the umbrella cells again will prevent urinary tract infection. Tam-Horsfall protein secreted from distal convoluted tubule and ascending limb of loop of Henle, which will reduce the type 1 fimbria, which we are going to talk later, with the urothelium, and which will activate phagocytosis of the bacteria. Mucosal defense, like locally secreted immunoglobulin, will prevent urinary tract infection. And presence of glycosaminoglycan layer, which will inhibit the invasion of bacteria in the urothelium. We'll talk about the virulent factors of E. coli, which will be important in prevention of recurrent UTI later on. We are going to discuss. It has many types of pili or fimbriae and afimbrial addition also. Type 1 fimbriae, which will cause FimH addition molecule, which will attach to the monosylated residue in the blood mucosa. In P. pili, which will attach to the galactose glycolipid in the kidney, which will cause pyelonephritis. And there is called S. pili, which can cause cystitis as well as pyelonephritis. And they can cause cytoskeletal disarrangement or rearrangement via cytotoxic necrosis factor. Again, it prevents phagocytosis or apoptosis of this organism. And then iron scavenging mechanism, they produce hemolysin, and then with that they make pores into the urothelium. And then formation of biofilms, which is covered by extracellular matrix, which will protect them from antibiotic. And other virulent factors like toxin production, enzyme production, locally acting antihumoral products, those will act against host defense. The risk factors, whatever the issue they are with storage and voiding, can be functional or structural, which will cause urinary tract infection. And then inadequate fluid intake, which will increase the risk of urinary tract infection about 2.2-fold. And vaginal douching, bubble bath, new sexual partner, lack of urination after sexual intercourse. It has been shown that 79% of bacteriuria has been noted within 24 hours of intercourse. And then use of spermicide, that has shown 43% of preceding, if there's a sexual intercourse or spermicide used within a couple of weeks, there's a chance of bacteriuria by 43%. And pregnancy, foreign bodies, immunosuppression obviously, estrogen deficiency, menopause. There are many causes due to loss of acidic pH, postmenopausal, presence of pelvic organ prolapse, urinary incontinence, deterioration of functional status of the patient, and there is evidence of a history of premenopausal urinary tract infection. Genetic play a part there. Presence of childhood infection, first episode of urinary tract infection before the age of 15, and if the mother had history of UTI, there is a chance of urinary tract infection. And blood group, that P1 blood group phenotype, they have the susceptibility to get urinary tract infection. What is the word term for significant bacteriuria? The Cass has introduced this term in 1960s. He said it should be more than 10 to the power 5, but it's been disproven because 20 to 40% of women had symptomatic bacteriuria even with 10 to the power of 2 to 10 to the power of 4. So the current theory is women, if we call them to have cystitis or uncomplicated cystitis, even 1000 coliform unit is enough. For the uncomplicated pyelonephritis, 10,000 is enough. For complicated UTI in women, which should have 100,000. In men, always UTI is complicated in men because there is obstruction. There is no uncomplicated UTI in men. So in men, it should be more than 10 to the power 4. And any count in should probably be puncture sample collection. any count is significant. So how are you going to approach a patient? The clinical symptoms or the signs and symptoms is going to be different with anatomical infection, severity of the infection. We wanted to take a good history with previous history also, whether it is a recurrent UTI or a single episode of UTI, any predisposing factors, and then examination, general examination with abdomen, genital, as well as neurological examination. Symptoms, you take cystitis, it should be like frequency, like storage symptoms mainly, frequency, urgency, dysuria, suprapubic pain, often they will come as hematuria also. Pyelonephritis again depend on the severity, fever, nausea, vomiting, flank pain, and costovertebral angle tenderness. What are we going to start with is investigation. As Professor Senna said, we have to start with dipstick test. You have to check whether there's a presence of blood, nitrite, and leukocyte esterase. If you take nitrite, it has high specificity. In other words, if the nitrite is positive, it is more likely the patient is having urinary tract infection. But negative nitrite will not exclude urinary tract infection. And if you combine leukocyte esterase and nitrite, the specificity is almost up to 98%. So now we're going to do microscopy. Culture depends on the growth, and the amount of growth depends on the sample collection. And urine cultures are recommended even in EA guidelines when we suspect acute pyelonephritis, symptoms that do not resolve or recur within 4 weeks after the completion of treatment, women who present with atypical symptoms, or in pregnant women. Otherwise, no need to do cultures. Imaging, again, renal ultrasound scan, not indicated for every patient, even with complex or difficult to treat urinary tract infection, or persistent hematuria, where we have to exclude any other blood pathologies, or infection with proteus, where we have a suspicion of urinary tract stones. For pyelonephritis, we have to do imaging to rule out any upper tract obstruction. Again, other investigation should be case-based decision. Again, it's the same thing depicted in here from EA guidelines. Perform urinary culture and antimicrobial sensitivity test in patient with pyelonephritis. Perform imaging of the urinary tract to exclude urgent urological disorders. How am I going to start the treatment? So as I said, the incidence is rising, maybe due to like blanket use of antibiotic. Estimated rates of ESBL is rising, mainly in our part of the world, and carbapenem-resistant enterococci, vancomycin-resistant enterococci, all the incidents are rising. So the UK or Europe, we start smart and then focus. We have to take cultures when you're starting antibiotic, if indicated, and then focus on the empirical antibiotic and then change according to the sensitivity test. Which antibiotic? Always remember this 4D. What is the antibiotic? What is the dose, duration, and de-escalation? The choice of antibiotic may differ according to the local guidelines, local strain pattern, susceptibility pattern, tolerability, cost, as well as availability. If you do not adhere to this antibiotic policy, there may be incidence of multi-drug resistant organism. Cystitis, simple or uncomplicated cystitis, single dose of oxomycin or 3 to 5 days course of appropriate antibiotic enough. No need to do cultures even. And the point I want to stress here is do not use aminopenicillin or fluoroquinolones to treat uncomplicated cystitis. These are the drugs suggested by EA guideline. So nitrophenolate 5 days is enough. How are you going to follow up a patient with uncomplicated cystitis? No need to repeat urine dipstick or culture if they are asymptomatic after treatment. Only indication for urinary culture is if symptoms do not resolve by the end of the treatment or symptoms recur within two weeks. Pyelonephritis again depends on the severity of the condition. If it is mild to moderate, we can start with oral antibiotic. Duration also differs, 7 to 10 days, sometimes 14 days. If they cannot tolerate oral intake, we can start IV, but when it is possible, it is always recommended to switch off to oral antibiotic. Again, you can start with quinolone, ciprofloxacin as a first-line treatment for the uncomplicated pyelonephritis, and then even empirical treatment for uncomplicated, again ciprofloxacin, levofloxacin. The second line treatment tazobactam, gentamicin, amikacin. Last line alternatives is imipenem or meropenem. Follow-up, again routine post-treatment urinalysis and urine cultures in an asymptomatic patient after treatment is not indicated. We have to follow up patient with urine culture for if the symptoms do not resolve within 3 days or symptoms recur within 2 weeks. What about pregnancy? Even in pregnancy, there is anatomical and functional alteration of the urinary tract, increased renal volume, increased renal vasculature, dilatation of the upper tract more on the right side, and then pressure on the bladder and disoriented voiding. The presence of asymptomatic bacteriuria is around 2 to 7%, and if it is untreated, 30 to 40% will develop symptomatic pyelonephritis, and then they can go into low birth weight and preterm labor. So the NICE recommends asymptomatic bacteriuria should be treated in pregnant women with urine culture and sensitivity test. Safe antibiotics, cephalosporin and coamoxiclav. These are the antibiotics we should avoid in pregnancy. Quinolone and tetracycline all 3 trimesters. Trimethoprim T1, nitrofurantoin in T3. Aminoglycoside we have to avoid in T2 and T3. Postmenopausal, they are more reluctant to have urinary tract infection because of lack of estrogen. Acidic urinary pH is lost because of atrophic vaginitis. And then studies have shown estrogen replacement, local estrogen replacement will reduce the duration of antibiotic usage and then reduce the UTI by 75%. And guidelines recommend local application of estrogen for postmenopausal. We move to prevention of recurrent urinary tract infection in women, because 27% of women will have another episode of urinary tract infection within 6 months. So we have to take general measures to prevent those, like adequate fluid intake, frequent voiding, avoid prolonged bath, bubble bath, emptying the blood after sexual intercourse. With that, we are moving to other non-antibiotic treatment options. Number one is cranberry. It's a Vaccinum macrocapra. Active components are fructose and proanthocyanidin. Earlier we thought it increases the secretion of epuric acid, which will reduce the pH of the urine, which is disproved later on. Studies have shown more in favor of cranberry use. The current theory is there are 2 components of cranberry. Number one is proanthocyanidin, which will inhibit addition of P fimbriated, which we have discussed earlier, that causes pyelonephritis, so which will inhibit the addition of P pylori. Then fructose, it will prevent the addition of type 1 pylori. With that, the collective evidence is it will reduce the risk of UTI. But having said that, issue with cranberry use, the researchers or the studies has wide variation of product what they have used and the dosage also, and the unspecified organism, bacterial counts, and definition of urinary tract infection in the studies they have carried out. So because of that, EA guidelines, the recommendation is weak, but it can be used. The dose needed should be at least 36 milligram per day. Prophylactic antibiotic to treat recurrent or prevent recurrent urinary tract infection. There is a place to use because studies has shown with using prophylactic antibiotic will reduce the incidence of recurrent infection. NICE recommends prophylactic antibiotic for treat recurrent UTI should be considered, but after addressing to the other general measures. What antibiotic we are when are we going to use the antibiotic? There are three options. One is self-directed. When the patient feels that she has the urinary tract infection, she can start. No need to do urinary deep stick, neither urine culture. If the symptoms do not resolve within 3 days, then she will be asked to do urine culture. Postcoital prophylaxis, if the incidence of urinary tract infection is related to sexual intercourse, that has shown the recurrent urinary tract infection in placebo group it was like 80%, and in postcoital group it was 13%. Or else the third option is low dose, long-term use of prophylactic antibiotic. The problem with that is it can cause antibiotic resistance, and once stopped, 60% might have recurrent infection. Choice of antibiotic, there are studies which have compared different kinds of antibiotic like nitrofurantoin, norfloxacin, trimethoprim. All the efficacy was same, and if you want to use nitrofurantoin for more than 6 months, pulmonary and renal monitoring should be, hepatic and pulmonary monitoring should be there. And pregnancy, we have discussed, safest option would be cephalexin. Other option for non-antibacterial, non-antibiotic prophylaxis, D-mannose, methenamine, glycosaminoglycan layer protection, vaccines, and immunostimulants. We'll go one by one. D-mannose, it binds to FIM or FIMH, the type 1 pili, prevents binding to epithelium. It reduces the risk of urinary tract infection, like this. And weak recommendation in EA guidelines to use D-mannose. Methenamine, it produces formaldehyde, mainly in the presence of vitamin C. For the strong action, we have to get vitamin C with methenamine, which will reduce the pH of urine. Thereby, it will reduce the occurrence of recurrent urinary tract infection. Glycosaminoglycan layer protection. Without the presence, bacteria can invade. If we give mucosal barrier like Eloril, sodium hyaluronate and chondroitin sulfate, there will be induction course as well as maintenance course, which will protect the GAC layer and prevent the invasion of bacteria. In weak recommendation, it should be an intravesical instillation, weak recommendation by the guideline. Vaccines, it can be orally or local vaginal immunization, or even sublingual vaccines are available. So they can prevent occurrence of recurrent infection. And then immunostimulants, so vaccines, it's like a acquired immunity for a specific organism, and then immunostimulants, it encourages the whole immunity as general. So it's a serotype of heat-killed or inert pathogenic bacteria upregulate the immune response to urinary tract infection. It reduces the urinary tract infection or recurrent UTI by almost 40%. Strong recommendation for use of immunoactive prophylaxis. It is sold commercially in Europe. So take-home messages. UTI when virulence overwhelms the host defense. Presentation may differ from patient to patient depending on the severity. Always perform urinary dipstick test and consider urine culture and imaging when indicated only. Management starts from elimination of modifiable risk factors. Be mindful when starting antibiotic. Remember 4Ds: the dose, the duration, the drug, and de-escalation. Antibiotics should be, asymptomatic bacteriuria should be treated in pregnancy to avoid preterm labor and low birth weight. Consider non-antibiotic management strategies in prevention of recurrent UTI. As urologists, we wish all will have this fruitful flow without any trouble. Thank you.